Good evening, everyone. On behalf of Maharashtra Academy of Pediatrics, a very warm welcome to all the respected seniors, colleagues on Zoom as well as YouTube Live. Today, we have an eminent speaker with us, Dr. Prakash Vaidya sir, and the program will be moderated by Dr. Anjali Gokar ma'am. She is IAP President of Palghar, and over to you, ma'am. Ma'am, kindly unmute.
Ma'am, kindly unmute yourself.
Anjali, you're muted.
Ma'am, try again. Ma'am, I'm sending request to you. Yeah, you are unmuted, ma'am, now.
Okay. Yeah. Good evening, everyone, and sorry for that initial glitch. Some time ago, there was this why this cola very D, and that was the time when I first realized that there's something called going viral, and Dhanush had made that song go viral. And it was in 2020. It was when the virus struck in a very big way. It was not just as pediatricians or doctors who knew about viruses, but the whole world. And it was these not that we didn't know about viral infections earlier. We knew about polio, and we knew about measles and chickenpox, and long ago, even before we knew much about it, was smallpox. And it was with the armamentarium of vaccines that we just felt that somehow COVID is coming under control. We got measles, we got every polio under control. And 2011 we said, oh, we are so lucky, and we've managed, we've done it, we've got India free of polio. And then in 2020, it was COVID-19 that brought not just India, but the whole world to a standstill, brought us on our knees. That was the time we realized that there is something mightier than us. And then we said, no, we have to go. Yet we humans are great. And we said, we'll come up with a nice vaccine. And we came up with a nice vaccine. And just when we thought that we are seeing the last of COVID, children started going to school and coming back with a whole lot of infections, and they're coughing and they're getting fever, and we have the flu and we have H1N1. And then if that was not enough, they're erupting into rashes. And now we have something called the tomato flu and the monkeypox. So viruses are very smart. They're smarter than humans. And it's not just a matter of luck or magic. There's a science behind it. And to explain to us all this in a very lucid way, in a case-based presentations, in something, we need somebody, and not just somebody, a strong antibody. And that strong antibody today is Dr. Prakash Vaidya. And Dr. Prakash Vaidya is, I'm very happy to say, my husband's colleague from college, from GS Medical. And so that makes him a senior pediatrician. He's practicing in Mulund. And he has taken up pediatric pulmonology, which is such a very important subject as his favorite subject. He's decided to learn more about it and also share his learning and teachings with others. And he's been a joint national convener of the asthma training module. He's been in the writing committee of under 5 visas, and he's been in the committee of writing antimicrobials responsibly, all such important subjects. He's been a national trainer for the IAP NP-EP module for tuberculosis. He's been a past president of the IAP Thane branch, and he has his publications in 4 index journals, and he also has a 1 textbook chapter to his credit, with such an illustrious person to today talk to us about infections going viral. What is the science behind it in a very simple clinical case based approach? And for that, over to you, Dr. Prakash Vaidya. Welcome to this meeting today on an auspicious day.
Thank you so much for those kind words, Anjali. And I thank the Maharashtra IIP led by Dr. Gangulia, Dr. Pawar, and specifically Dr. Samir and Dr. Bhandarkar for this invitation to share this platform with you. So I'll be talking for a while, and then we'll be very happy to have a discussion as soon as I'm sure Anjali will do a wonderful job moderating it. So without further delay, I will go into my presentation. Is it visible?
No, not yet.
No? Okay. Is it visible now?
Yes, yes.
Yeah.
Yes, Prakash.
Yeah. So as Anjali mentioned, we now know the concept of what is going viral means. The way it spreads rapidly from person to person, and we all had an experience in COVID. That COVID was the first infection that really went viral. But today everything is going viral. So you'll ask me what's new about pediatricians facing children with recurrent infections. We've always had them. And most of us are busy in practice because infections are recurrent. We all know that from many studies that average child has 4 to 8 respiratory infections per year. They may even have 10 to 12. And normal infections can extend beyond 2 weeks, so that the normal child will often have even 10 infections in a year. But today something has gone beyond that. So what am I going to talk about today? I'm going to take a look at the prevailing scenario, why all infections have suddenly gone viral, trying to make sense of why this has happened. I'll have a number of case stories to share with you. And most importantly, I'll be dwelling on, can I come to a more precise diagnosis of this virus infection? Which are the available tests and how do I use and interpret these tests in my practice? And does such a diagnosis make any difference to the management? So we'll go across this entire canvas in the time allotted to me. And so we all know that we have overwhelming number of infections today. That's why most of us may not have even finished OPD for the day. So they are widespread, spreading virally, severe, frequent, and also there are more infections, more hospitalization. And we know that all these people are here: HFMD, enterovirus, respiratory, influenza, para-influenza, RSV, all the viruses in the galaxy, dengue, rotavirus, and COVID has never really gone away. Plus, as Anjali mentioned, there are some new diseases on the block. One is monkeypox, and the other is tomato flu. So tomato flu has been even featured in Lancet as a disease in India, but it could be an after effect of chikungunya or dengue, or it could be an enterovirus. But I mean, it's just a variant of what we have already been seeing. But one thing is common, that what is a recurrent scene in our clinics? It's the mother tearing out her hair and saying, "Doc, give me something to increase my child's immunity." Now, the first question is, when they say that, it means that they suspect that the child has a immunodeficiency. So is it really immunodeficiency as an epidemic that we are facing? Quite obviously not. And I don't need to tell all my knowledgeable colleagues what immunodeficiency really can be summed up as: SPUR. And SPUR is, of course, severe, persistent, unusual, and recurrent. So infections that are severe, persistent, caused by an unusual bug, and recurrent. But today, none of these four, all these four are not there. It's only recurrent. And again, my illustrious audience doesn't need any homilies from me on antibiotic giving unnecessarily. But in the past, we've always had people thinking that fevers were antibiotic deficiency. And parents still think the same. So many parents tell me that, "Doctor, so many times my child is falling ill, you don't know to give an antibiotic." So we have to really spend time teaching them that this is not an antibiotic deficiency fever. And finally, the new concept that has come up, that is immunity debt, which most of you might have heard about. So what is this immunity debt? So what immunity debt is: loss of immunity to viruses, which was suppressed by the COVID lockdown. If you remember what happened in the COVID period, we were having absolute separation. We were having masks, social distancing, and we were doing hand washing. So not only COVID, but all other viruses also stopped spreading. But what has been the upshot of that? What has happened is that because of this NPI, that is the non-pharmaceutical interventions, non-pharmacological interventions, all viral infections had actually got suppressed. It's like a forest fire, as epidemiologist Michael Baker explained. He said, take the example of bushfires. When you have bushfire every year, it's not very severe. But when you have a bushfire after 4 years, there is so much combustible substance on the ground that the bushfire is usually very severe and rages for a long time. So infections have been suppressed for 2 years and now they have made a huge comeback. And this is an experience across many countries. But before I take up the scientific models for this, I'll first share some cases with you. And I've had these 3-4 cases which were quite shaking, which quite shook my confidence. I had this 11-year-old boy with fever, cough, vomiting, altered sensorium since 1 day. X-ray chest done showed haziness of the right lung. Child had to be intubated in the emergency room, shifted to the PICU, clearly had encephalitis, CSF done, normal. He was started off on antibiotics IV and antivirals. And the nasopharyngeal multiplex PCR detected influenza A H3. So basically, this was a case of influenza which went to the CNS. And on day 2 of hospital stay, he also developed picture of an acute kidney injury with a creatinine of 2.24. So the pediatric nephrologist who reviewed the child said it's a kidney injury. And we saw an article which said that renal involvement in children with influenza is not at all uncommon. It has been reported even before today many times. I had another child, a previously healthy 3-year-old girl, came with high-grade fever, cough, cold for 3 days, seizures, 3 episodes, which were self-limiting, which were generalized chronic tonic, and then came with an altered sensorium, received anticonvulsants. This girl had not received the flu vaccine. And again, febrile encephalopathy. Dengue was negative. EEG showed generalized slowing and influenza A positive. This was non-H1N1. And the brain, of course, showed areas of thalamic problems, thalamic altered intensity. Then I had one more child. Again,
Just a minute, Dr. Prakash, can you please go back to the MRI picture and just keep it for a while?
Okay. Yeah.
Okay.
So this was I have many cases, so this doesn't really particularly prove a point. That's why I skipped it. There's altered signal intensity in the thalamic region, which is one of the hallmarks of the H1N1 encephalitis.
Okay.
So there was post-contrast enhancement and symmetric signals of altered signal intensity in bilateral thalami, bilateral basal ganglia with thalamic hemorrhages. And the DD for this is dengue, malaria, and H1N1, but here we had an H1N1 positive. Then I had a third child who came with a severe respiratory distress, almost went into ARDS, and it was H1N1 positive. So when I go back in time for all these 3 cases, what do I find? That all 3 were previously healthy children. All 3 presented with only cough, cold, and fever and worsened over 3 days. So somehow influenza in a serious form is very common now. And we often tend to give oseltamivir on suspicion. And we'll talk about oseltamivir, the pros and cons of giving. Also, is an H1N1 swab enough? So that I'll be discussing in a little more detail later on. But of course, at this time, a word of caution, which I'm sure all of us really don't need, that we should not miss dengue because the initial presentation of dengue can be very similar to influenza. So my contention here is that influenza has become much more severe. Is it really a sign of the immunity debt? So the first projection of immunity debt came from this Swedish group, which said that children and their mothers have not been exposed to RTI for last 2 years. And therefore there is going to be excess susceptibility due to lack of immunity. And why mothers? Because mothers do transmit the passive antibody to their infants, and therefore infants have been more at risk. So their projection suggested that there will be a lot more hospital admissions and severe patients in the coming times. And this is really what happened in the Scandinavian countries. In 2021, they found there's a sharp peak of hospital admissions due to RTI, and the number of patients requiring respiratory support by RTI, that is, let's say CPAP or HFNC or even oxygen, was much higher. So there was definitely this signature of an immunity debt, which was showing in the form of children getting more frequently admitted and getting more severe disease. And but it wasn't really due to influenza in all countries. Like the study from Germany said that corona, Boca, parainfluenza, and RSV returned as frequently detected pathogens after the withdrawal of major NPI, that is non-pharmacological measures. But they said that in their series, influenza A and HMPV, human metapneumovirus, was notably absent. Then there was a very interesting study from New Zealand, which said that bronchiolitis is coming back in a big way and you're paying the immunity debt with interest. They had 1,000 cases for a country like New Zealand that's very, very large of admissions in that particular season in late 2021 after the COVID restrictions vanished. So they said that this is also due to immunity debt, because immunity debt causes upsurge of the virus, and whatever infections were held in abeyance came back in a very big way. And this has been reported in France, where they had a lot of intense spike in RSV, parainfluenza, human metapneumovirus. Here, notice it is human metapneumovirus. So viruses have been different in different countries. And this was the data from the National Respiratory Surveillance Center in New York, which said that reduced circulation of RSV during winter has resulted in severe symptoms and severe number of patients now. One of the reasons, interestingly, was that many children were not in daycare in COVID times, and now they came to daycare. So this is a combination of children. We are not following COVID norms. There are no masks. There is no separation. There is less of hand washing. Children are going back to daycare, and all that has resulted in an immunity debt, which has come in a big way to catch up with our children, and therefore has been responsible for us being over busy in our practice. But the other possibility of the number of infections being reported high could be that we are doing too many tests today. Is that right? So this way the wheel has gone full circle. When it was COVID at its peak, every single fever, cough, cold, we used to do a COVID antigen or a COVID PCR. And today, even when I know a child is COVID, I would probably not want to do a COVID test because it's treated like any other disease. But we are more inclined to do the flu test, and the number of cases of H1N1, this was a month back, it had surged. Today, there are much more. And we are more keen on doing the flu test this time. But flu test is, of course, far more expensive than the COVID test. So that brings me to this the crux of my talk today. That is viral RTI only a diagnosis of exclusion, or can I proactively, or should I proactively test for that? So far, available tests had lacked sensitivity and specificity. Today, doing tests for virus identification is probably an idea whose time has come. Or really, is it true? We'll just analyze this. So which are the tests that are available for which viruses today? So we have this multiplex PCR, which is famously known as BioFire to most of us. It is only a brand name like Xerox. So you get respiratory viruses in that, influenza virus, para-influenza virus, you get human RSV, respiratory syncytial virus, you get rhinovirus, metapneumovirus, adenovirus, and of course you get coronavirus, as well as now you get SARS-CoV-2. So all these tests are available with us. Apart from that, you can also get measles, CBV, enterovirus, etc. But not in this particular panel. So the question that we ask is, fine, these tests are available. Is it cost effective or worthwhile picking up an RSV by doing these panel tests, or any other virus for that matter? So first of all, let's see how common is RSV in India. And there have been studies about the burden of RSV respiratory viruses. And this is a study which said that RSV has always been high, 36% in some, 48% in South India, 37% in our part of the country, 32% in North India. So very common. The other viruses which are common are rhinovirus as well as influenza virus. So viral RTI is very common, that's for sure. And this is also the conclusion that the burden of ARI and ALRI is high. Upper respiratory means respiratory upper as well as lower respiratory due to RSV is very high. Having known this, does it really help me in my practice to pick up an RSV infection by doing these expensive tests? So is it worth proving RSV? Now, so many viruses cause bronchiolitis, right? It is RSV, it is metapneumovirus, it is rhinovirus, it is the flu virus, it is parainfluenza, it is adenovirus. Even SARS-CoV virus can cause a bronchiolitis syndrome. So does it alter my management? Does it change my prognosis? Let me take you through a case. This was an 8-month-old child with cough, cold, and fever since 3 days, irritable, restless, typical picture of bronchiolitis with no similar episode in the past. He received a standard line of treatment, which is, of course, hardly anything. What we do is do supportive. We just take care of the hydration, take care of the oxygen, and some of us would like to even give a hypertonic saline nebulization. But beyond that, normally we don't do anything because often beta-2 nebulizations do not help. And you have the parents very hyper all the time, child crying, and the parents are very anxious. They want to know why is my child not improving? What is the diagnosis? And they said, doctor, we don't mind spending. So here we did this test. We did a multiplex PCR, and what we detected was RSV plus human rhino and enterovirus. How do I interpret this report? Which of the viruses is causing this syndrome? Is it RSV? Is it rhino? Is it entero? Is it all three, or is it none of the above? So when you look at the literature on the subject, what you find is that rhinovirus is a frequently found pathogen in 47% of the controls. It is present in both symptomatic and asymptomatic individuals. So when I pick up a rhinovirus in a child who is symptomatic, it may not be the cause because you may get it even in asymptomatic people. But in contrast to that, when I get an RSV, it is almost always the cause of infection. And the same is true for H of human metapneumovirus as well as for the adenovirus. So when I pick up something, I should know the predictive value, the positive predictive value. And the positive predictive value of RSV is pretty high, not so high for rhino, but high for the other two viruses. So what is the culprit? RSV. Was this test required? Well, it helps me in the epidemiology. It helps me to pacify the parents, and it possibly helps me to step down on the antibiotics if I've already started. But again, the bottom line is there is no recommendation for viral testing in an otherwise healthy child with bronchiolitis, and I don't want to state otherwise. Let me take you through another case of a child who came with really severe wheeze, and he came to my office with severe wheeze, did not settle down with beta-2 inhaled, and I had to admit a child. The SpO2 was low, so I had to admit him and give this child nebulization. Again, affording parents who wanted a diagnosis. So we did the test and it turned out to be only rhinovirus. Now, here, the RSV was not detected, flu was not detected, only rhinovirus was detected. Could it have been the cause? So in this context, yes, it could have been the cause. And my belief in this was strengthened because this child actually improved within 2 to 3 days, became fine, and actually went home on day 3. So the outcome of bronchiolitis, if as in practice, we should know what are the key factors that really matter about the outcome in bronchiolitis. So let's understand that among this study, where 900 infants were studied with bronchiolitis, those who underwent intensive care, they were more likely to be wheezers and have asthma later on. Is it the cause, or is it that the inflammation that they had itself caused lung damage, or is the intensive care causing the problem? We have no answer to that. Or is intensive care only a marker of these babies who are at risk for chronic respiratory problems? Is it that children who are genetically predisposed to severe infections, they may also be predisposed to wheezing? So any of this can be true. But what is true is that children who have severe problems in their first or second episode of bronchiolitis tend to be frequent wheezers. So recurrent wheezing was 22% amongst wheezers in all. And history of eczema is a powerful correlating factor. But does RSV versus non-RSV help you here? So some of the studies have shown that RSV episodes were more severe compared to non-RSV. And this is, in my limited experience, this is my experience as well. So RSV episodes tend to be more severe, the cough tends to be longer, and these children tend to get recurrent problems as well. So how does it help me in my practice if I know that it is RSV positive? It's not that I'm telling you as the standard of care, but it is my routine practice that if I find an RSV child, I know that this cough is going to last for a long time. So in this child, I am upfront going to be very keen on shifting him onto a metered-dose inhaler therapy if he is wheezing. Not that all of them are wheezing, but a wheezing due to RSV does very well with inhaled. And this is the child I will introduce on the inhaler early on because this is the child who is likely to get recurrent wheezing. And here, if the child really gets recurrent wheezing, I'll be happy to start him on an early ICS trial. How about antibiotic use? How many of RSV children get secondary infection? And many of us in RSVs who don't improve tend to start antibiotics because we feel that now it is a secondary infection. But in a prospective study of 500 plus children, only 1.2% had secondary infection and bacterial pneumonia. So it is extremely rare. It is just that RSV takes long and we need not be in a hurry to start antibiotics. Now, some of you may say that, yes, it makes sense to identify RSV, but isn't there a cheaper test? My patient can't spend 13, 14, 15,000 rupees. So now there is a very good bench to bedside test called as the RSV antigen. And this test is available in Mumbai today. It's available in some hospitals. Hinduja, for example, has it. I'm trying to get it in my own place. And the cost is about 1,000 rupee a test. So in 1,000 rupees, really, you can tell the patient whether it's RSV or not. It has a good sensitivity and specificity, but it will not detect any other virus. So this is called as a rapid antigen test based testing or a point of care test. But I am now talking of not this one, but something that we more often do, and that is the respiratory panel. That is that so-called biofire, which panels which we have, where there are a multiple number of antigens of viruses which are detected and 4 bacteria. These 4 are Mycoplasma, Chlamydia, Bordetella pertussis, and Parapertussis. If I do this test, does it really change my management much? Are there any pitfalls? So in any case, before I test, I have to be very honest with myself and find out whether it affects my clinical management. Sometimes you do have to do it because of parental pressures in affording parents. I mean, that is not actually a clinical reason, but I would say it is a reason that really, to be honest with you, is one of the reasons in my practice. And of course, you must be aware of the pre-test probability of a given pathogen because it affects the positive and negative predictive value of these assays in a big way. And if I decide to do, which test should I do? Now, this is a more difficult to answer question because many of us would do a COVID test. If COVID antigen is positive, then probably you feel that it is COVID that is responsible for the symptoms. But that is not always true because we know that the COVID virus lingers on, especially a COVID PCR may come positive for a very long period. And I do not know whether the COVID virus which you detected in the PCR is the cause for the problem, right? Same with influenza. Now, if I do an influenza test, some hospitals have a very single test for H1N1. So if I do H1N1, can I be satisfied that this child doesn't have flu? Not at all, because H1N1 is only a type of influenza A. And unless your panel detects all influenza A, you're not very sure. Also, influenza B is coming up in a big way. So ideally, your influenza panel should have both H1N1, means it should have both A and B, where H1N1 will automatically be detected. But if you're doing only H1N1, probably it is not serving the purpose. You may get misled. Again, with influenza tests, there are too many conditions which apply. One is that when you detect influenza, a negative antigen test may not exclude influenza infection. A positive test does not exclude other. A PCR usually excludes, but it again depends on how that PCR was taken. Was it taken the right way? Was it taken with the right technique? Was it processed properly? So sometimes you do get negative PCRs also. Again, a positive influenza test in a PCR does not mean that other pathogens are not there. So also, if I get an RSV, does it mean that influenza is excluded? Not really. So one more important story is that all these cases of encephalitis, which I showed you, we could not document the influenza virus in the CSF because our lab said that these tests are not validated. So there are some labs which will test in the CSF for influenza, but to the best of my knowledge, all the big hospitals like Hinduja, for example, even our hospital, we are saying the test is not validated and you cannot test influenza in the CSF. You have to only extrapolate. So which brings me to the point I'm making, that this was a 14-year-old child with cerebral palsy, an obese child. He had high-grade fever, cough for the last 4-5 days. And at home, the parents did his COVID antigen and they said, my child is COVID positive. So and he was breathless, so I had to admit the child. The COVID PCR was done, which also came positive. But clinically, this child had an acute flu and he had not been given flu vaccine. So I had to start here oseltamivir as well. Now, am I justified? Here I'm getting a COVID test positive. But here I'm having a child who is immunocompromised, whose respiratory reserves are poor, who has not received a flu vaccine, who is obese. So can I really rule out flu on the basis of just a single test? So for this, you find an answer in the IDSA guidelines, the Infectious Disease Society of America 2018 update. What they are saying is that in an area of high influenza activity, a negative result of a flu test, that is, I'm talking of the molecular assay, the PCR, a negative flu PCR may not be true negative, but in a patient, so NPV is low, negative predictive value is low. If the patient has a lower respiratory tract disease, then the negative predictive value is low. If it's got an upper respiratory, it may be high. But my patient clearly had a lower respiratory tract. So consider potential for a false negative test, especially if it is collected in a hospitalized patient. So what the IDSA is telling in effect is that if it's a high flu season, it's a susceptible child with LR, with lower respiratory infection, then do not go by the NPV of a influenza test PCR alone, which is negative. Let me take another child who came to me. It was an 8-month-old baby who had to be admitted in PICU with an acute wheeze and respiratory distress. Child had not been sleeping for 2 days, but parents actually did not realize he was very sick. When they came to me, he was desaturated, his SpO2 was 80, and we had to admit him into the PICU. So his CRP was 78, and being a PICU admission, we had started him on Fluir because flu vaccine was not given, and we had started him on ceftriaxone as well. As you might excuse a serious child who is very sick, obviously none of us would take a chance. So now when we did his swab, we got RSV plus rhino. So for a minute, I ignored the rhino. So this was probably an RSV causing bronchiolitis. Can I, in a PICU child, stop Fluir and ceftriaxone, knowing that the child is sick? It's a very gray area. So it really depends on how much. So here, honestly, I did not stop. I knew it was RSV. I was not 100% sure it was not flu because the child had not received flu vaccine, and we could not go down because the child was in a PICU, but we did stop as soon as possible after the child came out. So the point to tell you is that sometimes these tests do give mixed signals, but then how do I know that a test is reliable or not? Does CBC CRP tell me that it is viral? Not at all. We all know that there are studies after studies which tell you that CBC CRP sensitivity and specificity is 70 and 65% only, which is certainly not good enough to tell me whether it's bacterial or viral. So what is the impact of these multiplex PCR virus tests? Are they really helpful? Well, in developed countries where there is a good antibiotic stewardship, and whether we also in hospitals which have good antibiotic stewardship, they can definitely help to reduce unnecessary antibiotic usage. And the targeted use of antivirals can also be made, but it is not that evidence-based. And the second thing is we can initiate infection control measures. But so far, I would not say that there is a very strong argument for doing multiplex PCR in all the patients. So what had happened in the US in the past, that in flu season, antibiotics were massively used in children because nobody knew it was flu. But this was studies up to 93. This is not true today in the US. But it is still true in India, where even as early as day before yesterday, Lancet published this report saying that 44% of antibiotics are unapproved and not necessary. So impact of NAT testing on influenza outcomes has always mainly tested influenza. And I can tell you one thing, that influenza testing has the potential to reduce unnecessary antibiotic use. But before I talk about that, I talk about a very important point of how we talked about how virus detection occurs in both symptomatic and asymptomatic, both type of patients. There was a study way back in 2011 which said that asymptomatic carriage is present, but the number of viruses, amount of virus is much lower in asymptomatic versus symptomatic. But again, COVID taught us that number of cycles really was not a measure of severity, because it really depends on the time that you took the sample. It depended on how the sample was taken. So the quantitative value of a PCR test was always a gray area. So we have still not found any cutoff levels which tell you that this is the quantitative cutoff for a virus which is asymptomatic versus a virus which is causing the disease. So this still remains a gray area, though this thought came way back in 2011, but we have not been able to work on this. Now, I had a very interesting child who came from the US, who in the US, they do viral tests for every episode. So this child had 5 episodes of infections in about 3 months, and he was a nursery going child. So 5 times they did the test and they found 5 different viruses. Once they found RSV, once they found metapneumo, once rhino. So this gave me confidence to tell my patient that, look, your child is falling sick repeatedly, but each time it's a different virus, and immunity of one virus does not translate to another. So this is something that that was a take home from this, though I can't say that I would do this test in India. I can't do it all in every episode. That's not feasible. So am I now telling you that in the Indian setting, tests are always useless? I'm not telling you that. I'm going to share you 3-4 cases of tests which have really been useful. So this was an 10-year-old boy who came to me on day 2 with fever with rigors, and fever was 105, 106. So parents insisted on admission. The child was actually not looking that sick, but because of the high-grade fever, we could not take a chance. The child also had headache. There was no clear focus of infection, but there were tonsillar crypts. His total count was 13,000 with a polymorphic predominance, and his CRP was 32. But here clinically, I was so very sure that it is flu. So at that point of time, since I could not get a follicular tonsillitis or anything, I did not start antibiotic. And when I did the test, this child's influenza A PCR came positive. This was a case of flu. And within 2 days with oseltamivir, this child was fine and went home. So really, I could avoid an antibiotic because I got a very clear diagnosis on this basis. This was a very interesting case of a 2-year-old boy with fever cough since 4 days, admitted to a private nursing home, came with pneumonia, was given ceftriaxone, did not settle down. On day 9 of illness, he came to me. He was transferred to our hospital for tertiary care, and his antibiotics by then had been stepped up to linezolid, and as well as I think some amikacin or something outside. He was very sick when he came, and he had consolidation bilaterally. So it was a pneumonia of some etiology. We did all investigations, myco, IgM, cold agglutinin negative, no pneumatoceles. There was really no sign of necrotizing pneumonia. There was no effusion on the USG. CB-NAT was negative, and by now the child was very sick. He was on NIV, he was on Vanco and meropenem. And we did his nasopharyngeal biofire, and that was positive for adenovirus and rhinovirus enterovirus. So ignore the rhino entero. This was adenovirus, but did I have the guts to stop antibiotic only on this basis? How do I interpret this report? So we said that it is probable adenovirus, but the child was still very sick, so we dared not stop the antibiotics. But what we did was, we then did his BAL and bronchoscopy. And a culture was done from the bronchoalveolar lavage, which showed no organism at all. And the BAL biofire showed adenovirus. So this was a conclusive proof that this was an adenovirus pneumonia. Here, therefore, we could stop antibiotics. We could, reduce it very quickly. And this child did well and went home gradually. So this child was gradually weaned off NIV, went home. And this is where a biofire test really helped me get a clear-cut diagnosis. Then there was another case of an 8-month-old girl who came with sudden onset of stridor. This was the flu season that the child had not received flu vaccine. This was a case of croup. So a multiplex PCR was done because the parents were ready, and it showed para-influenza. So here, with this, I got the confidence to do 2 things. A, not give an antibiotic and not even give oseltamivir. And this child settled with the usual symptomatic treatment of croup of nebulized noradrenaline as well as nebulized adrenaline as well as maybe steroids. But this child did very well without using antibiotics or oseltamivir. So sometimes these multiplex PCRs do help. So don't go with the idea that they are not useful, but we have to pick and choose the patient, and we have to pick and choose the situation. And before I end, we are going to talk about the virus that really supports pediatric practice today, and that is the enterovirus. So we are all busy, and even our receptionists are able to diagnose enterovirus infection. We know that. So which is the dangerous enterovirus? What is my concern? We know that this HFMD is going to get well in a few days, but what is my concern? Which of the HFMD is dangerous? Which of it is going to have neuro complications, and can I pick it up in time? So one thing is, before I talk about that, one thing that I need to tell all of you is two cases in my own hospital, and this both involved residents. The first was a 4-month-old child who came with just not feeding well. And this child, the mother insisted he's not even taking anything. The child is oliguric. And as often happens in there, nobody had seen the throat. And when I saw the throat, it was nicely herpangina, and the child was not feeding because of that. I had one more six-year-old child. Again, the residents, they saw everything, but they didn't bother to see the throat. And the throat had shown herpangina, and it was very clear what was the diagnosis. So when you look at the throat, the diagnosis is on a platter. And of course, I don't need to tell this to my audience, but sometimes in a busy OPD, we may miss it out, and we may miss out a diagnosis which is on a platter. So I'm saying that doing a throat infection, examination often gives you a clear diagnosis of enteroviral infections. So the oral lesions of enterovirus are normally caused by, these are caused by A71, which causes HFMD, and Coxsackie A6, which causes HFMD. It is the A71 enterovirus that can cause neuro complications and not the Coxsackie A6. But should we be actually looking at it? The answer is no. Now we have herpangina or HFMD, which is basically a clinical syndrome. Remember that HFMD is not a disease, it's a syndrome because it is caused by multiple Coxsackie and multiple other enteroviruses. What is the difference between HFMD and herpangina? Both are caused by enterovirus serotypes. Herpangina is usually confined to the throat and does not have any manifestations of the on the skin, whereas HFMD usually has, of course, has skin manifestation. That is actually the main difference. It is caused by very similar organisms, and the treatment is, of course, symptomatic only. So the virology of hand, foot, mouth disease and herpangina is Coxsackie virus, echovirus, enterovirus, same viruses which can cause both kind of manifestations. This is from Up to Date. So they say that in their country, they would do stool, vesicular samples, PCR. We do none of the above. So if we do a nasopharyngeal swab, the rhinovirus and the enterovirus are picked up as the same organism because our PCRs are not able to differentiate between rhino and entero because of the sequence homology of the 5-NCR. So it is the different species is the same, the serotype is different. But that doesn't matter. So who are the patients who get neurologic complications? The enterovirus 71 genotype. How do I know that this child is going to get neurologic complications? I would be looking for, of course, early signs, and those are fever, myoclonic jerks or seizure, headache, convulsions. This is something that if it happens, then I would definitely start looking for a neurology. Luckily, in my experience, I have not had a single, maybe a patient so far with a typical HFMD going in for encephalitis. But I would like to know what all of you do feel about this. And in Korea, they had analyzed the RT-PCR positive, and they find that the RT-PCRs in the CSF was only 7.5% even in neurologically affected children. So even if the child has got neurological symptoms, it is not such a great idea to look for an enterovirus in the CSF because your isolation possibilities are not very high. Now, this disease is sometimes confused with HFMD, and it is herpetic gingivostomatitis. But we should not confuse the two because this has got a different treatment. It has got a different appearance. The gums usually are friable. It's very painful. The gums are bleeding and the ulcerations are much more severe than HFMD. They may get covered with an eschar. And if at all you get skin involvement, that skin involvement is asymmetric and not symmetric like HFMD. So which brings me to the important question today, that there are some of my colleagues who say, I give acyclovir in all HFMDs. Are we justified in giving that? So let's understand that the genome of enteroviruses does not encode for thymidine kinase, which is necessary for acyclovir activity. So acyclovir is not the standard of care for HFMD or herpangina, though it may be a standard of care for herpes gingivostomatitis, which is caused by the HSV virus. So what is the role of acyclovir? I looked at two studies. In these two studies, they had used acyclovir in the treatment of severe HFD, hand, foot, mouth disease. But both these authors said that the reason it worked was not antiviral. It must be through the patient's own interferon. This was a study from, I think from the from Europe somewhere, and this was a study from India, from Pune. Dr. Damle, a dermatologist who used oral acyclovir for severe HFD, and he also said that it is believed to work by modulating the patient's own interferon. So we really don't know how it works, but the standard of care for starting for HFMD is not to give acyclovir. What about recurrent? I'm sure all of you are seeing recurrent HFMD episodes. So we used to see them recurrently, maybe on a yearly basis. Today, I'm seeing them back to back. They come in July, they come in August. They may come again in September with HFMD, or at least 2 episodes back to back. Why is it happening? Well, we know that it's a syndrome. There are 2 different viruses which cause it, not only 2, multiple different viruses. So that is why you do get HFMD again and again. This is another question I'll put to the house. Is the second episode more severe? I have seen this in some of my patients. So I think in India, with such huge numbers, we should, all of us, make a note of that and try to have a publication based on this. But yes, HFMD is coming recurrently and the episodes tend to be more severe. So before I end this talk, one more disease that has made a big comeback in the post-COVID era is MDR-TB. And that is something which again brings us home to the point that today we dare not start TB treatment without doing a microbiology, because this is one more disease. Though it is not a viral disease, it is another disease that has made a very big comeback. So to sum up what I told you, infections have gone viral today. There are many multiplex platforms which identify respiratory pathogens, but differentiation from carriage of carriage from infection is always a challenge, and co-infection is also a challenge. So it is the clinical correlation that is a must when we look at these tests. So what is my take-home message? There are lots of tests for diagnosis of viral infections, but we need to interpret them very carefully. We need to counsel our patients on what is immunity debt, what is the importance of isolation, and very importantly, the importance of giving vaccines for treatable conditions like, for example, flu, and the precautions that they should take in not sending children to school while they are infective, so that the circulation goes down. Not that parents usually listen to this, but I usually tell them 7 days of isolation. But there is some practical value of this test in terms of reassuring the parents what it is, avoiding antibiotic abuse, knowing the epidemiology, and sometimes using targeted treatment in LRTI. Definitely, there is a use in immunocompromised hosts and when the diagnosis is doubt, especially in very sick patients. It helps in infection control and planning epidemiologically. So these tests are available, but they are not necessarily to be used in each and every patient. We have to pick and choose and use them with care. So thank you for your patient hearing. I will now stop sharing my screen.
Thank you so much, Prakash. That was such a wonderful deliberation on the very, very common situations we see, and putting it in a case-wise presentation really brought it to the fore. This thing of immunity debt is something that's new I've heard, and I'm sure a lot of us have. And that brings home the point why we are getting so many respiratory infections now. And I think there were a few questions in the chat which I will take up, and I think Dr. Ramakant Patil has said, how rational will it be to give empiric oseltamivir in pneumonia with distress without H1N1 test, and if flu vaccine not given in otherwise immunocompetent host?
I'm sorry, what was the first question?
The question is oseltamivir indicated in an immunocompetent?
Yeah, so across all guidelines, in a sick child in a flu season, 100% we would like to give oseltamivir because we have a window where it works well. And that window is usually not more than 3 to 4 days. But having said that, even if a child comes on day 7 who is very sick, I would still give oseltamivir for the benefit of doubt. So yes, in a sick child, I'm not saying that each and every RTI I would give oseltamivir. If my patient is toxic, if he has hyperpyrexia, and if he is sick, without doing the test, I would definitely go for oseltamivir on the first day. But having the test come positive helps me. Having the test comes negative does not empower me to stop oseltamivir.
Dr. Ramakant, would you like to unmute and say something? Okay, he also has asked another question to which you have already given the answer. The newer viral panel on CSF claim to detect influenza, how validated is it? You said it is not validated.
So I've discussed with the microbiologists at our hospital and at Hinduja. So it is not validated. So there are some labs which will give you a report. Now, what gives them confidence to give the report? Do they really have the studies? I have no way of knowing. But most of the standard labs are not, for them, it is not validated. So we are not able to actually detect the flu virus in the CSF. I'm able to see Vijay there. Maybe he can add his comment. Vijay, would you like to say something?
Yeah, Prakash, wonderful listening to you. It was a fantastic deliberation with so many case scenarios. Yes, you are absolutely right. You are absolutely justified in giving flu in high flu season, which is what we are going through currently. And second recommendation is, second thing that I would like to bring up is, do we say that first 3-4 days is the best time to give anti-flu medicine? However, in children, the shedding and infectivity is longer than adults. And we have seen anti-flu working even if when started late. We have seen children, I do it. So LRP,
7 days we give it. That's what I said.
7 days, 8 days also. So that you give. Prakash, can I make a few points?
Please do.
One thing is co or superadded infection on an underlying viral respiratory infection is not an uncommon phenomenon. However, it is rare with RSV. So in the Western world, RSV PCR is used as a very good AMSP tool, and they do discontinue antibiotic. However, in influenza and metanimo, that may not hold true. One point that you made was in severe bronchiolitis, your threshold for putting this child on MDI later is very high.
Yeah.
All of us understand.
Very
You
low.
also made it
Very
very
low.
clear that low. You also made a point that all of us also practice the same way, that we don't use bronchodilators in acute bronchiolitis. But in these patients, especially those who are born prematurely, who have had some support at birth, so do you use bronchodilators in these cases of bronchiolitis? It's a very difficult decision to make. And what is recommended is usually you give, if a patient responds, you continue, otherwise you discontinue.
That is exactly
what is your recommendation? What do you do?
I follow guidelines. I first look for audible wheeze, for auscultatable wheeze. If wheeze is there 100%, now is that wheeze getting reversed with my bronchodilator? If it is, I'm justified in continuing. But many times there is no wheezing at all. So there I would not give a bronchodilator at all, because it only adds to the tachycardia without benefiting the patient.
And very well driven home point that you must look at the pre-test probability before ordering a test. And that also for so many other tests in infectious disease. So your positive predictive value would be, dictated by your pre-test probability. So I had one more question. I'm forgetting. Anyway, in the meantime, if somebody else has to ask or make a comment, please go ahead. I'll try and recollect. There's one more question that I wanted to ask you.
Thank you so much, Vijay, for your
may I ask one question to Dr. Vaidya and Yoli sir also? Now, in acute encephalitis patients, many times when the turnaround time of all these CSF panels, BioFire and PCR, is more for the tier 3 cities and taluk places, all these things. How to prevent a shotgun therapy of giving azithromycin, oseltamivir, acyclovir? All this shotgun therapy is given at least for 48-72 hours. And many times the CSF picture also doesn't help us. So will you like to shed light on this? How to prevent this shotgun therapy in acute encephalitis?
Dr. Ramakant, I would believe that treat what is treatable. So while shotgun therapy is not something that we like, but then whatever is treatable has to be treated if you don't have any evidence to the contrary. Would you agree, Vijay?
Yeah, but Ramakant, partly yes, polytherapy and encephalitis is a standard recommendation. One. Secondly, I totally agree with Prakash. But however, we tend to herpes simplex has its signature, and usually seen in adolescent and older children. It's not so common in very young children.
Yeah.
Azithromycin, the recommendation came from a few studies where the prevalence of mycoplasma causing encephalitis was very high, to the tune of 10 to 12%. I remember Dr. Udani's case series also. And that is when, Prakash, if you recollect, we made that PSPID module and we talked about azithromycin. However, there is a school of thought which says that azithromycin really does not cross the blood-brain barrier. But at the same time, encephalitis is immune-mediated. So for whatever work to take care of the load in the circulation, you do give azithromycin. But if you have a proven case of mycoplasma encephalitis, the drug of choice would be fluoroquinolones and not your azithromycin.
Even one more, sorry to interrupt, but azithromycin is not the organisms of the CSF, it is the immune response.
Absolutely, yeah.
So don't really know whether it's helpful, but
correct.
To cover what is treatable.
And antibiotic one would not really use if you have ruled out acute pyogenic infection. So the question remains whether you would use anti-influenza medicine in this, if there is an epidemiological evidence of high circulation in the case of influenza. My answer would be no. Again, influenza has signature on MRI or clinical presentation. You have that thalamic and midbrain involvement in influenza. So empirically, one would not use anti-flu medicine. Dengue encephalitis you manage symptomatically again. So Brahmakan, yes, regardless of whether you send or don't send this test, encephalitis, you start treatment with polytherapy and then you get rid of the treatment which is not applicable in a given case.
Vijay, my question to you is, why not give oseltamivir when we want to treat what is treatable? Is it really going to cause a lot of harm to the child? And can we not, by withholding, by not treat what is treatable?
Influenza is known to cause encephalitis, but as I said, it has signature on MRI. Thalamic involvement and the midbrain involvement. It's not so difficult. I mean, there is an overlap with flavivirus encephalitis and this thing.
So if you are not able to do an MRI immediately, many times in a
maybe in a place
why not give the benefit of the doubt, whatever the benefit.
That's fine. Yeah. But then again, influenza doesn't occur around the year.
I'm talking of the flu season for sure.
In flu season, yes. Yes.
By grace of our colleagues, this may become a medico-legal problem also in future. That may become an act of omission also. So that is it is at the time to come, but that may be the situation. In that case, what Dr. Vaidya sir says, I really endorse his view.
True. But Ramakan, at the same time, Consumer Protection Act and this fear of litigation has led to a lot of over-investigation in irrational practices, unfortunately. Itna bhi nahi darne ka.
So I think the underlying point is that yes, polytherapy would be justified until you have a clear diagnosis to the contrary, and also stepping down would be prudent after 48 hours. So I think, Dr. Ramakant, that will always be a debate to do or not to do.
In a sick patient, not in a non-sick.
Of course, in a critically sick patient.
Anjali, I want to make one point. I was forgetting that time. HFMD. We are having a very bad, prolonged outbreak of HFMD all over the country this year. The peculiarity that we are seeing is back-to-back infection in a short period of time and extensive involvement. Trunk, axillae, and so much so that one of the kids looked like monkeypox, Extensive lesion all over. Prakash, I'll share the picture with you. It is such a bad.
We are all
and Dr.
All of us
Prakash
are seeing
also,
that.
Yeah, I think Dr. Prakash also asked this question whether the second infection was more severe.
I was coming to that. Not necessarily. We have seen children where secondary not necessarily.
But I think we have such a large opportunity to collect data on HFMD when there are thousands of us practicing and getting so many cases. In India, we don't really collect the data.
Prakash, in Navi Mumbai, we are doing Anjali, in Navi Mumbai, we are into a small study with the ICMR.
Oh, great. So I think a lot of us can also get into that. And if Dr. Prakash is willing to take up a registry for this, then we'll be very happy to report to you, Dr. Prakash, and just do send us a
I think
Google
we should
form.
take the initiative and
But Anjali, registry would not really tell you much unless it
It's
is
a
backed
test.
by some molecular testing.
Yeah.
You know, so we
So
would like
okay,
to
let us
know
join.
if back-to-back
No, even-
infection, if there are two different viruses strains which are involved.
No,
That
at least
makes
the
sense.
clinical, at least some clinical data collection on what is the morphology, how severe is the second episode, what is the difference. So at least that data with so much prevalence we should have, But I think otherwise we can hop onto Vijay's bandwagon and send him samples if you
Yeah.
allow.
Yeah, I think so.
Prakash, I remember the question that I wanted to ask you. You mentioned about a child with stridor,
Right.
and I think para-influenza. No?
Para-influenza.
How often have you seen influenza with stridor?
Not very often. Not really.
Not very. No, I have not seen. So that is what I wanted to ask you. Whether do you see stridor? And this year we saw a lot of myositis in influenza.
Yeah, so that was Dr. Ramakant's another question, whether we would be justified in a flu-like symptoms with myositis to give oseltamivir. So that was one of his questions.
If you have ruled out dengue, yes, and dengue NS1 takes only few hours to do.
Correct.
Okay, yeah.
But
That's
Prakash, I have a question to this now. I had a child who had severe myositis, CPK in 10,000, but by the time he developed myositis, fever had disappeared. And we had sent, and his H1N1 came positive. Would you use anti-flu on such a child?
Probably no.
Yeah, we did not use of this.
No.
Yeah.
Yeah, so Dr. Ramakant, does that answer that question?
Yeah, I perfectly agree with Evile sir that whenever a patient is myositis only and no prodrome, in that case there is no role for antiviral or oseltamivir in that this thing. Fortunately, we have not seen EV71 particularly with neurological complications. But is there availability of pleconaril or rupentrivir? Have anybody any experience of pleconaril? Because encephalitis cases we may get the way rampant EV71 or probably A16. As rightly said, that EV71 will have more of a propensity for CNS infection. That is one question. And second is slightly non-academic. But what is my experience? This is an observation that older infants, 9-10 months, who are having bronchospasm, not responding to beta-2 stimulant or adrenaline nebulization, but I give them slow adrenal drip by syringe pump. And these are the babies without antibiotic. They stop crying, their tachypnea decreases, and they respond very well. So are there any studies like this? How rational it is? Is it absolutely very wrong, or what is the opinion of Evile sir?
What drip? Adrenaline drip?
Yeah.
No, I have not come across publications which have described this method of treatment, to be honest with you.
I would not have the guts to give adrenaline.
I must have used it in 20 to 30 patients with 0.05 microgram per kg per minute. And these are the babies who have dramatically stopped their crying because they start crying at 3-4 a.m. and they do not stop till 6 a.m. And many babies after that, when they start crying at 2 a.m., after 1 hour, 1.5 hour, we start them after nebulization and all those things. If they are not responding, 3% sodium chloride, epinephrine nebulization, and with 0.05 microgram per kg per minute. And in 2 days, their tachypnea, everything responds. And they are weaned of all these things, even IV fluid, hydration, and everything.
Dr. Ramakant, in 2 days, patients are usually better in any case.
Yeah, but I mean, what the basis of parenteral adrenaline?
Is it to reverse bronchospasm that you are giving, or some other reason?
So, what I'm not able to recollect, but there is definite role of not bronchospasm, but the bronchial edema, which is being taken care by adrenaline, not the bronchospasm.
Yeah, but topical, na? I mean, parenteral adrenaline taking care of edema, I don't know.
Already given, but it is not responding. But I have given at least till this date in 20 patients, and they have dramatically responded to this. Of course, before that, I have done X-rays. I have done all the sorts of like nebulizations, 3% sodium chloride, epinephrine nebulization, and even I have given in 1 or 2 patients steroid also.
You should think of publishing this data then, because this will be new to most of us. I have not come across.
Yeah, but I don't think they should go across as a recommendation.
No, this is not. I am saying.
It's your experience. Thank you for sharing your experience,
Of course,
Dr.
I said it
Ramakant.
is non-academic. I made an initial disclaimer. This is non-academic unless until it is proved by RCTs, at least unless it is published in some index journal. This has to be. But I did read in some pediatrics published in 1971, which said that this epinephrine, I will try and find that, and if I come across, I will send the reference to Vaidya sir and Nivale sir.
Thank you so much, Dr. Ramakant, for sharing that. Dr. Prakash Vaidya, there was a question by Dr. Pooja Thakur, who said that is RSV vaccination available, because abroad they are giving it for preventing RSV infection.
So RSV vaccine was on the threshold of being launched before COVID displaced it. So I don't think it has yet been launched anywhere, Dr. Pooja. It is still a vaccine that is going to come, but COVID derailed it completely. So I think it will now come in the next couple of years, or maybe earlier.
Sir, one of my patients from Germany has received it. So,
to the best of my knowledge, it has not been launched anywhere in the world. What about you, Vijay? Do you know if it has been launched?
This Germany child must have been enrolled in the
Trial.
It's not commercially available yet.
Yeah.
And Prakash, this RSV antigen, Dr. Balasubramanian from Kanchaka Mukherjee Child Trust, one of his DNB students did a thesis on RSV antigen.
Okay.
And I was just going through the literature about a year ago or so. I vaguely remember, at a reasonable prevalence of RSV, the sensitivity is reasonably good, about 50 to 60%.
It is a very, it has got
it's a very cheap test.
And specificity.
And what he told me, the test cost is about 300 or 400 rupees only.
Yeah, so our hospital, it was initially available for 1,000 rupees. So it is available, but because the demand was not so much, they discontinued it.
What about using palivizumab as a prophylactic for preterm babies for RSV?
It's only for very high risk infants who are preterm, who are ventilated, and who are going to have it. I have not used it.
Yeah, another problem we see is that if you look into the years of many of the children who come with repeated infections, you'll always find that there is some ASOM or there is some otitis media. Now, do we treat this, because some of them do come with, recurrent fevers and sometimes even with nasal discharge. So what is the incidence of otitis media following respiratory infections, and how would we go about, treating with antibiotics?
Now, there is enough data that otitis media is primarily a viral disease, though there is certain percentage of all these usual respiratory bacteria being involved in otitis media. So it is not at all uncommon that some of these viral infections will have a concomitant otitis media as well. Though I can't say that it is a very common thing that I have seen. But yes, there is a viral component to otitis media in a large number. I think Vijay will agree with me probably.
Yeah, absolutely. And one of the common complications of influenza is otitis media.
So the question is that how would you now treat this as where bacterial and viral would come in? So is there a way we would be able to distinguish and say that this child would qualify for an antibiotic therapy?
Depends on at what point. Yeah.
I think there is a very clear-cut algorithm and guideline on treatment of otitis media with antibiotic. Below 2 years, be a little more proactive. Again, mild disease, unilateral disease, wait and watch. Bilateral disease, you give maybe co-amoxiclav. Otherwise, mild disease, you start with amoxi, and if the child doesn't respond, amoxicillin is standard dose, by the way, 40 mg per kg. If the child doesn't
works with otitis media.
Absolutely. But then again,
if you are going to do it in the first place.
Otitis media is one disease where you have an opportunity to practice what is known as delayed antibiotic practice.
Yes.
You can always wait and watch, unless the child is sick, who has severe otitis media.
There's a clear algorithm, as Vijay says, and initially you don't have to rush for antibiotics unless the child is toxic or a very young infant.
Absolutely.
Yeah. Dr. Neha, are there any questions on YouTube?
No, ma'am, I cannot find any other question.
But Prakash,
Yeah.
it is always a pleasure listening to you.
Thank you, sir.
Prakash, would you like to say anything about monkeypox, and have you seen any cases? Because
Absolutely
I
no
think there was.
experience at all. It's
Yeah,
only
there
that a patient diagnosed monkeypox when it is actually a very severe case of HFMD, but
Yeah.
I have not diagnosed and nor have I had any suspicion of monkeypox.
Yeah,
It's-
and what about this tomato flu? And is there any patient you would say that this is tomato flu or this
So,
is
as I said
HM?
in my first slide, tomato
HFM.
flu may be a enterovirus or it may be a sequel of dengue or chikungunya. That is still in doubt what it is. So, it is just a morphological description, nothing more.
I think tomato flu is same as HFMD.
Yes.
Vijay, there was this article in Lancet where which is what I shared in my first slide. I don't know if you were there.
I missed that probably.
So
Okay.
they speculated that either it was a variant of enterovirus or it was a sequel of chikungunya or dengue. I don't know how they came to that conclusion, but that was in that Lancet letter to the editor.
What I read was in UK, these children with papillovesicular rash, they isolated enterovirus, and it turned out to be only. And this was a term coined by, I think it came out in Kerala, from Kerala.
Yes. Media term.
I think they have.
So we have a
I
lot
think
of first in India, Dombivli fever, tomato fever.
Very fruitful terminology.
Yeah.
Yeah. So, any more questions? And
Ma'am, I have one question, Dr. Amrita.
yeah,
here.
please. Yeah, Dr.
For
Amrita.
Dr. Prakash Vaidya, sir. Are there, clinically, when do you strongly suspect a case of monkeypox as against this enteroviral epidemic that is going on? And are there any investigations, any PCR that is available today for monkeypox or for that matter, the tomato flu?
Amrita, the way it started, where COVID started and we were asking history of foreign travel, I think we start with that history, whether there is really travel to countries which are affected with monkeypox, because we still don't have an endemic, fortunately, in India. But my personal experience of monkeypox is zero, so I cannot answer that question. Sorry. If Vijay can shed any light, I don't know.
Lymphadenopathy is one thing that is known in.
Child will be very sick in that case. It's a very
sick child, pain rash, and lymphadenopathy. And as Prakash said, we have not had any case of monkeypox in children in India at all.
Yeah. And any investigations available, sir?
Again, molecular tests.
Yeah. Prakash, we didn't get it.
PCR from the vesicle fluid is what is recommended, but I don't know whether that test is even available or it has to go to the NIV. Yeah.
Yeah. Are we seeing any viral diarrheas at the moment? It's all respiratory.
No, plenty of them. In fact, enterovirus disease, it is an enterovirus. So many times, many of these patients also have a concomitant diarrhea as well. And many of these viruses are multisystemic. So diarrheas are pretty common in this.
But I don't think it's on that epidemic scale as we are seeing the respiratory.
Rotavirus is another virus that has not been reported to have been part of this immunity debt, to the best of my knowledge, because I think the vaccinations have continued and rotavirus has not made a big comeback in COVID times. But I think there are other viruses where we have been seeing more viral diarrheas for sure in the early part of post-COVID period when things opened up, but not currently.
Yeah.
Anjali, one observation, since people from Maharashtra there, since last 2 weeks or so, a lot of cases of dengue, and what is speculated, a lot of patients are going in that critical phase very quickly,
Okay.
Day 2, day 3, and we lost one of the children who were transferred to Apollo Hospital, and a lot of, at least 5 or 6 children came in shock. Quick progression to critical phase and leakage. I thought I must.
Good, because day 1 doing an NS1 will, put us in the correct direction.
So, really, I want to comment one thing.
Yeah, please, Jagdish.
I agree with Vijay that severe HFMD would look like monkeypox, and lymphadenopathy would differentiate. And that patient which we had referred had lymphadenopathy associated with this rash. And another thing, history of travel is not the criterion for diagnosis, because rodents are also known to be the vectors for monkeypox. And now Zika also, we had a child from Ashram Shala who
Dr. Jagdish comes from Dahanu. So so he's talking about Palghar district and Dahanu. Yeah, Dr.
From
Jagdish.
that school, when there was an episode outbreak of H1N1, lot of children suffered from H1N1. One child was had a death, and when that child was analyzed, she was found to be positive for Zika. Now Zika also, there is no history of travel. It's not prevalent, so much prevalent in amongst us. So how do we differentiate?
No, the lymphadenopathy in monkeypox is generalized lymphadenopathy, sick child and painful rash.
This child was sick. This child was sick. He had extensive rash. There was a history of contact, similar patient, similar rash, and he had a lymphadenopathy.
Dr. Jagdish, your patient's PCR was sent. Did it turn out positive? What was the result?
No. Actually, I told you that time they messed it up. And afterward, they said, because initially they said there is no history of travel. I said, no, WHO doesn't say that history of travel is essential. And when I referred this to state level monitoring team, they said they reprimanded that particular medical officer, and he said, don't take the decisions at your level. Please send the samples. But by then it was already day 6 or day 7. So we don't know.
Yeah. And I think another important point that Dr. Jagdish had made at that time about this case was that the lesions were present even on the head, which was not generally seen in HFMD, and also there were no oral lesions. So that was the differentiating point which he had found, and severe lymphadenopathy.
It was a suspicion. It was our duty to notify these patients who come like this with a rash, lymphadenopathy, and a history of contact. These are the 3 or 4 criteria which WHO recommends.
Okay. And you made a point about the Zika virus as well. So there was this report. So that Zika virus was detected in one of the ashram shalas, and I think another child from the same school also had a Zika virus.
When there is no history of travel, Zika is not prevalent amongst us. We have never seen a Zika virus infection here.
So I think if we start doing PCRs, we are going to get a lot of surprises.
Then only we can find out. Right? It was very well pointed out by our surveillance officer, Chavan, Dr. Chavan. Kishore. He said rodents are also the vectors for monkeypox.
Yeah, thank you for sharing your experience, Dr. Jagdish, because these are 2 different cases than what we had discussed today. 2 different viruses.
Yeah, thank you.
Yeah. Any other comments or any other, Dr. Prakash, you want to say something?
No, there's any more questions, otherwise we will.
Yeah, it was really wonderful, Dr. Prakash. You presented such wonderful cases and such an array of cases, right from encephalitis and renal acute kidney injury and bronchiolitis, ARDS, so a spectrum of respiratory infections, and so many studies to show, the validity of tests and otherwise, and how to interpret viral tests and viral PCRs, multiplex. So many things for us to do and so many things to learn. Dr. Prakash, thanks for putting Prakash on so many aspects of respiratory infections. Wonderful. And with this, I think a lot of viral infections are actually going viral now, and we need to be prepped up. Virology, like genetics, we used to say, nahi, ye sab viruses hai. So except for a few like polio and measles, we would read up. But I think now we need to go into the fine print of Nelson and all other texts which tell us about metapneumo and rhino and adenoviruses and a lot more viruses, because they are going viral. So thank you for this wonderful deliberation and all those who participated, Maharashtra IAP for taking up such important issues of discussion for common pediatricians. I thank everyone today on the panel. I thank Maharashtra IAP Dr. Hemant Gangolia. And with this, I hand over to Dr. Neha Singh.
Thank you, Anjali ma'am. Viral, go away. Please don't come back again and again. We cannot fully avoid a viral infection, but to some extent, we can reduce the chance by taking precautions and timely vaccination. Precautions at home, at daycare, at school, hygiene followed by parents, school staff, like proper cleaning, sanitizing of the toys, floors, making sure kids doesn't share their water bottles, cutlery, kerchief with the other kids. We cannot avoid illness entirely from our life, as illness teaches us the importance of our health. It's just a phase that will pass, but with precautions, vaccination, and proper medical support, it doesn't take us to serious trouble. And as we have just faced a serious challenge of COVID-19, now let us take any serious risk with our little ones, even if it's a normal infection. Avoiding antibiotics, going with symptomatic treatment is most important, but we have to keep our antennas up. Thank you, Dr. Prakash Vaidya sir. You have excellently brushed up today's topic, and that too in a very simplified but interesting way. I also thank our Maha IP President Hemant Gangolia sir, Secretary General Amol Pawar sir, Scientific Convener Jay Bhandarkar sir, and Sameer Sadavarte sir for organizing this wonderful subspecialty program. Also, thank you Dr. Vijay Yevle sir, Dr. Ramakant Patil sir, Dr. Jagdish sir for active participation and giving us their point of view too. Thank you, Dr. Anjali ma'am, for wonderfully moderating today's program. Thank you, Pallavi ma'am, for all the technical backup. Also, thank you to all the other attendees on Zoom as well as YouTube Live for joining us today. Thank you all and good night.
Thank you. Good night.